Hi, I just want to check if you guys can see my screen. Hear me okay?
Hey Jack, I could hear you. I also see the screen.
Yeah, we'll probably get started in a minute. Just having breakfast now. Okay, I think I'll just get started. So, I don't know if some of you were expecting Yi, but we switched. So I'll be doing antimicrobial review 1. I'm Jack. I think I've met some of you before. I'm the ID pharmacist at Wakefield. Just to give you guys a brief background of where I came from, I did my Pharm D at St. John's University, and then 2 years of pharmacy residency at NYU in the city. And then I've been at Wakefield for almost 2 years now. I've seen a lot of crazy prosthetic joint infections, which you'll definitely come to see when you come here. So we'll be going over a few antibiotics today, not all of them, particularly vanc, aminoglycosides, linezolid, quinolones, tetracyclines, and fosfomycin. You'll typically see these three a lot at a Wakefield when you're treating some of these bone and joint infections, the linezolid, quinolones, and tetracyclines. So these are just some important formulas for you. One is to calculate ideal body weight, and the other is to calculate adjusted body weight. And then obviously the last one is creatinine clearance. This is important for dosing. You're probably not going to remember this. So if you just go on Epic, you can find that adjusted body weight. You can find the ideal body weight. And then you can find the creatinine clearance. So you don't really need to memorize those formulas, especially for the ID fellows. But I think for the pharmacy residents, you definitely need to know these. I think this is assuming that the nurses and the team documents some of the patient weight and height. If they don't document it, then you're not going to have it in Epic. So we'll start with vancomycin. I kind of put out just a different coverage here. So in terms of vanco, it's strictly a gram-positive agent. It doesn't really cover gram-negatives at all. And in terms of its gram-positive coverage, this is kind of what it looks like. It covers MRSA, covers MSSA, but not as well as like a beta-lactam. That's why there's a plus minus. Definitely covers Enterococcus if it's not VRE, and then it covers strep for sure. It also covers some coag-negative staph as well as Cyanobacterium, which you may see in prosthetic joint infections. And then this is sort of how it works. Basically, it binds to diala, the last two proteins of this pentamer, and it prevents it from cross-linking with other cell wall components. And then you can see here for VRE, it changes diala to diala-D-Lac, and therefore vanc can't bind. In terms of its kinetics, it's a pretty bactericidal. It's a slowly bactericidal drug, meaning that even though it is bactericidal, it works slowly. So this is pretty much the reason why it's not as effective against, MSSA compared to a very rapidly bactericidal agent like beta-lactam. It's pretty poorly absorbed from the intestinal tract, so you're not really giving it PO unless you're treating C. diff, and then the majority of it is excreted via the kidneys. So we target an AUC of MIC ratio of greater than 400 to achieve clinical effectiveness, and um, this is really the true efficacy target, though we do trough monitoring more as a surrogate because trough monitoring is much easier and there's some correlation, though it's not perfect. So typically you'll see anywhere from 10 to 15 for skin and soft tissue infections, maybe a coag negative line infection, something where it's not that severe. You can kind of get away with a lower target, whereas we typically target 15 to 20 for anything else. So this is probably the most common adverse effect. Actually, it's not that common, but red man syndrome, I'm sure you've heard of it. It's just some things to note about it because you may see it as you're practicing or you're being consulted. Typically, it's an idiopathic reaction. It's not really related to antibodies, and it may occur with the first administration. It's typically related to direct mast cell and histamine release, and patients will experience tingling and flushing of the face, the neck, the upper torso, more so than the lower body. So that's something to keep in mind. They may develop erythema and pruritus, and all you do is just slow the infusion down. Nephrotoxicity is another very common side effect, particularly with piperacillin tazobactam. This has been pretty well documented in the literature, and then you may experience some ototoxicity as well. I just want to touch on this MIC creep. So for the most part, CLSI, they establish a breakpoint of 2 for vancomycin against Staph aureus. If it's 2, it's still sensitive, but we typically look at 2 and we know that it's a little bit harder to treat. So our sort of arbitrary breakpoint in our head should be 1. And the microlab even puts this disclaimer here where if the MIC is 2, they'll say that vancomycin treatment failures have been reported for Staph aureus isolates with an MIC greater than 1. And this is just something to keep in mind because the primary team may not know this. And for an MIC of 2, depending on what you're treating and where you're treating, you may want to use an alternative agent. And we've seen a lot of these. This was actually from a knee fluid. And this is why sort of these MICs of 2 don't really do so well. If you look at these 3 different MIC values, if it's 0.5, if it's 1, and versus these 4 dosing regimens, you can really achieve really this AUC of MIC of greater than 400, this PKPD target with these low MICs. But once it becomes 2, your probability of achieving this target is decreased tremendously. So we typically avoid basically vanc for high MICs. These are just some memes. Kind of struggling currently with some of the ED colleagues that order vancomycin for everybody. So I have some examples of dosing vanc because this is kind of bread and butter. Hopefully, once you graduate this fellowship or residency, you become an expert in vanc dosing. So this is a 60-year-old man. He comes in with septic shock, unclear source. You get an urgent page, need help with vanc dosing. He weighs 83 kilos, creatinine clearance is 60. And the question is, how would you dose this patient? So we have a nomogram. You can find this on Sanford Guide, or if you actually just order Vanco and Epic, it appears on the left-hand side of the order. So it's very easy. You can find this anywhere. The good thing about this nomogram is that it's pretty user-friendly and there's a lot of different dosing regimens. It's based on actual body weight. So you just have to make sure you're using actual body weight on the left-hand side. And you can't use this dosing scheme if patients are on AKI or on renal replacement therapy. This is assuming that they have stable renal function. So for this patient, they were about 80 something kilos and their creatinine clearance was 60. So they fall into the 1 gram Q12. The only bad thing about this nomogram is that it kind of fixes you to like a certain dosing scheme, which may not always be correct. And you'll kind of see why later on. So that's the only downside. The other way that I typically use the dose. I don't really look at a nomogram too much. I just use weight-based dosing, and this is what you'll see in some guidelines and other hospitals as well. Typically, you just give the patient 15 mg per kilo of their total body weight. You round it to the nearest 250. Now you look at their renal function. If they're an AKI, you're going to dose by level. If their creatinine clearance is less than 30, you just give them every 24-hour dosing. If it's greater than 30, you give them Q12. If they're young and their creatinine clearance is really, really high, greater than 80, you can consider Q8. The issue here with Q8, and you'll see later on, is that people accumulate really fast on Q8. So I typically cap them at Q12 unless it's something really severe. There's a few exceptions to this rule. You don't want to exceed 4 grams daily of vanc, and you don't want to exceed 1,500 milligrams per dose. So sometimes in OB, patients, pregnant females will come in. They'll be, they'll weigh a lot. The OBs will order like 2 grams Q8 or something like that, and that's sort of incorrect. It's just too much. So if you look at the nomogram, the patient will get 1 gram Q12. If you do, quick math, they'll get 1250 Q12. So it's pretty similar. This is a second example. So you have a 40-year-old man. He comes in with a horrible right leg cellulitis that wasn't improving on PO Bactrim. You get a 2 a.m. urgent page. Please help vanco dosing. Definitely not unexpected. He weighs a lot, 180 kilos. Creatinine clearance is 140. How would you dose this patient? So if you use a nomogram, you're going to come out to something that's 1 gram Q6. And the issue with 1 gram Q6 is it's even a step up above 1 gram Q8. For obese patients, you may need to dose them very frequently, or for people with high creatinine clearances, you may need to dose them very frequently. You'll typically see Q6 dosing in pediatrics because they clear so fast. And this is sort of the issue with the nomogram because we run into issues where patients just weigh a lot or their creatinine clearance is so high, and we have to resort to Q6 dosing. If you do quick math, you can kind of just give them a higher dose, but just less frequently, and you'll typically come to the same outcome. So this is what I want to caution you guys about with obese patients. This is something I ran into, or we see a lot actually. This patient was getting vanc. It was an obese patient. They were getting 1250 Q8 to start. For a few days, the creatinine clearance is normal. The creatinine was normal. They check a level, it's 12, and they react off of this. They say, okay, let's target 15 to 20. So they increase the patient to 1500 Q8. So you can see the total daily dose is 4.5 or 4,500. They check a level and it's 16.6. So they say, okay, that's fine. If you're not on top of this, obese patients will rapidly accumulate vanco. And this is sort of what happened with this guy. He went to 40 and then 77, and then lo and behold, the creatinine goes from 0.5 to 0.9 to 2. So it's not wrong to give obese patients a lot, but you kind of just have to remember to not give them too much and to be on top of it, because they'll be therapeutic one day, but then the next day you'll overshoot it. So monitoring for vanc is typically indicated for people with unstable renal function. They're receiving long courses of therapy. They're at high risk for toxicity, so they're receiving other, concurrent nephrotoxins. If they don't have AKI, we typically say to obtain the trough prior to the 4th dose. There's no magic to the 4th dose. It's just when the patient is kind of at steady state, you can get it prior to the 5th. It's not wrong. If you want to check a level earlier, make sure they're not accumulating, you can get it prior to the 3rd. I just don't want you guys to sort of like fall into the habit of just saying, okay, it has to be the 4th dose, has to be the 4th dose. It doesn't have to be. If they have AKI, you just dose it by level. And what dosing by level means is you just give them a dose, you obtain a random level whenever. Typically I get it with morning labs, so they can kind of just batch everything together. And then you redose them weight-based only when the level is less than 20. If you're treating like a skin and soft tissue, you can redose it when it's less than 15. And trough monitoring, I have this table here, but honestly, a lot of it is by feel. So for example, if you get the trough back, it's less than 10, you can increase the frequency, you keep the same dose. So going from like Q12 to Q8, if they're 15 to 20, you can increase the dose slightly. So on and so forth. But again, like I said, it's often by feel, and you'll kind of experience it once you dose more patients on Vanco. But I would say when in doubt, I would just err on the side of caution. For the most part, um, a lot of Vanco is empiric, and there's sort of no need to be super aggressive unless your patient is actively dying of MRSA bacteremia in case you can go wild. So I have a third example. This is a subtherapeutic trough. So you're treating a 50-year-old diabetic with MRSA osteomyelitis with Vanco 1500 Q12. They weigh 100 kilos. Creatinine clearance is 80. She's received 3 doses, and a true trough returns is 13.1. What would you do? Any takers? Anyone would bump it to 1750? Would you stay the course? Would you increase the frequency? We should stay the course because, like I mentioned before, in obese patients, they're going to accumulate. So, oh, I see a chat actually. Nice, yeah. So they're going to accumulate. They'll probably be greater than 15 with a few more doses. So there's no need to sort of react off of this. And also, you're kind of just treating a chronic infection, so you don't really need to be too aggressive. For renal replacement therapy, this is something you'll see a lot too, typically in the ICUs, even floor patients. Dosing is pretty easy in renal replacement therapy. You kind of just have to be on top of the troughs because patients will accumulate if they don't get dialyzed. So to start them off, you dose them initially 15 mg per kg for either 2 doses, or you can give them a big dose of 25 mg per kilo. And this is kind of just to load them. So if they're naive to Vanc, you can give these 2 or 1 dose and you'll get them therapeutic pretty rapidly. You'll see in HD patients. In terms of monitoring, monitoring is a little bit more complicated. Typically, we get a pre-dialysis level. And the reason why we get a pre-dialysis level is because you can almost predict a post-dialysis trough, and getting a post-HD level is a little bit tougher. So the pre-HD level can also be obtained in the morning with AM Labs. So it's kind of, less frequent sticks for these patients. HD, for the most part, removes about 30% of Vanco. So if you do some quick math, for example, if your pre-HD level in the morning is like 20, you can almost predict the post-HD level to be like 15 or so, or 14. And then you'll reassess the dosing based on the pre-HD level. So I'll kind of give you some examples. So for example, if the pre-HD level comes back as 10, you'll know that after dialysis, it's going to be even lower than 10. So you can kind of give them another dose based on what they weigh. If the pre-HD level is between 10 and 25, now you kind of have to think, like what is your post-HD level going to be? So you just take away 30%, you see if they're therapeutic. If they're less than 20, still, then you can give them a dose. If they're more than 20 post-HD, you can hold the Vanc. And then if they're greater than 25, you definitely want to hold Vanc because even if they get dialyzed, they're still going to be therapeutic. So you can see the dose ranges kind of vary depending on the weight. It'll depend on what the pre-HD level is, to be honest. So if it's kind of on the lower side, you can give more. If it's on the higher side, you can give less. The reason why we don't do post-HD levels is you kind of have to draw it at least 4 hours after completing HD to account for drug distribution. So if you draw it too early, the level is going to be falsely low. So it makes it hard to interpret. But if you do get it, it's kind of like a true level because it's actually after HD. So if it's less than 20, just redose them. Here's an example of dialysis. You can see that so this patient was on Vanc. They're not getting it every day. They're only getting it by level. The level they checked on the 10th was 30. You see after HD, it goes down. Like it's almost a predictable amount. They get HD again, it goes down a predictable amount. So this is the pattern that you'll see on people on Vanc getting HD. This is another example. Level was 7.7. They get 1 gram of Vanc, and you can actually use this to your advantage. So you'll know that for next time, 1 gram of Vanc gives the patient about 10 or so in their level. So it brought them from 7.7 to 17. They get HD, falls. If they don't get HD, you can see that the level barely changes. And then they get HD again and it falls to 10. So it's very predictable in this sense. In terms of continuous renal replacement therapy, this is actually even easier, in my opinion, because you almost assume an intrinsic creatinine clearance of 30 to 50. So you just give them 15 mg per kg daily, or Q24. And then if they're really obese or something like that, you can give them Q12. The only issue with CRRT is sometimes the machines clot and they have to kind of be switched over to intermittent. So that kind of messes with it a little bit. But if they're consistently on CRRT, then dosing is pretty easy. And then for monitoring, you just obtain random levels, within 12 to 24 hours and redose when less than 20 or less than 15 if it's less severe. This is hot off the press. So this is from sort of a lot of societies kind of jointly coming together to reevaluate how we monitor Vanco. And like I mentioned before, trough monitoring is just a surrogate for AUC over MIC. So this sort of guideline recommends actually obtaining the AUC over MIC and seeing if it's greater than 400. So I'll kind of show you guys how we do that. So like I said, the trough of 15 to 20 comes from this target because this target is a little bit harder to obtain and the trough is much easier. And this target is for both effectiveness and minimizing toxicity. The only caveat is that because it's kind of more difficult to obtain, we reserve it for more serious MRSA infections. So this includes like endocarditis, osteobacteremia, pneumonia. Exclusions are when the MIC is greater than 1, because like I mentioned before, you can't really obtain this 400 target if your MIC is greater than 1. For mild infections, you don't really need to, do this intensive monitoring, and then the renal function has to be stable. Otherwise, you can't really monitor them using AUC over MIC. So how to perform it? Just remember the rule of 3. So basically, we want to obtain levels after the 3rd dose. So when they're at steady state, you want to obtain, instead of obtaining just 1 level with trough monitoring, with AUC over MIC monitoring, you obtain 2 levels. So your first level is going to be 3 hours after you give the dose. So for example, if they get the dose at 12 p.m., you want to recommend the first level at 3 p.m. Your next level is going to be at least 3 hours after the first level. So if you obtain the first level at 3 p.m., the second one will be 6 p.m. Then you can call us and we'll calculate the AUC over MIC and you can modify your dose as needed. The one thing to note is that your troughs may be less than 15 or less than 10 sometimes, but this is okay because now we're using sort of a more accurate way to monitor. And you'll still collect troughs. You don't really need to repeat the AUC over MIC unless something drastically changes, but the troughs you'll monitor just to make sure it's not above 20. And this is sort of what I mean when troughs and AUC over MIC, it's not a perfect, troughs aren't a perfect surrogate. So if you kind of look here, we typically aim for an AUC over MIC of 400 to 600. If you look at the trough range of 15 to 20, which is what we target, on a day-to-day basis, you can see that we overshoot it a lot of the time. So you have some AUCs ranging in the 1200s and the 800s, and this increases the patient's risk of nephrotoxicity. On the other hand, if you target a AUC over MIC of 400 to 600, you can see that your troughs will range. So typically we're not getting really any troughs above 20, and most of our troughs are well within the 10 to 15 range. So it's not really a great surrogate, but if you can obtain AUC over MIC, this ratio, it's a much better way to monitor. The one thing with trough levels also is that even though we target 15 to 20, targeting a trough of greater than 15 actually drastically increases your rates of nephrotoxicity. So this is 4 studies sort of combined looking at Vanco nephrotoxicity, and you can see that with trough levels of 15 to 20, you're kind of still putting patients at risk. Whereas if you're greater than 20, the risk of nephrotoxicity is almost 30%. Here are some major risk factors just to keep in mind. Doses greater than 4 grams a day. So this is sort of why we have a soft cap. If they weigh a lot, again, obese patients, if you start off and their creatinine clearance is a little bit low, and you don't have these aren't like this is just from the study, but you can kind of keep it general. It doesn't have to be less than 87, but if they're low to begin with, typically ICU patients will experience more nephrotoxicity just because of all the different insults they have. And then one thing I note is that if you have a high initial trough level, so for example, if you get a trough and it comes back high to begin with, it's a sign that they may accumulate, or the current dosing regimen is a little bit too high. So usually a good trough that you want to aim for when you get it back prior to the fourth dose is actually somewhere from 10 to 15, because you'll know that they'll accumulate more, unless they're really sick, in which case you can target greater than 15 to begin with. And then the last risk factor is concomitant nephrotoxins, Zosyn in particular. This is just the last example. So this is a 32-year-old female. She's being treated for MRSA knee prosthetic joint infection in the left knee with rifampin and vancomycin IV, 1250 Q12. Her vancotroughs are repeatedly less than 15. Her calculated AUC is 480. Serum creatinine is stable. How would you modify her therapy? So you can see these troughs consistently below 15. The answer is stay the course, basically, because we know that troughs aren't a great surrogate. She's responding. So even if you didn't have AUC over MIC, the patient's sort of responding. There's no need to sort of be too aggressive. And the AUC is therapeutic. So we'll move on now to aminoglycosides. These are protein synthesis inhibitors. They're bactericidal. They're concentration dependent, meaning that you typically want to give more of the aminoglycoside up front rather than increase the frequency. They have a very strong post-antibiotic effect, and I'll explain what all these mean. In terms of clinical usage, for the most part, they're more synergistic rather than anything else. So typically you'll see them added on for, like endocarditis. You'll see Gent added on for like gram-negative sepsis. You'll see one of the 3 aminoglycosides added on to Zosyn or cefepime or something like that. The only exception is that for UTIs, you can kind of get away with monotherapy. So in terms of coverage, Gent typically is the only agent we use for synergy. So MRSA, MSSA, Enterococcus, strep, we can all they all can get Gent. In terms of its intrinsic coverage, it's strictly limited to gram-negatives and Pseudomonas. Tobramycin is pretty much Gent without the synergy, and then amikacin is kind of similar to these two. They also cover Mycobacterium, so sometimes if you have an NTM infection, you may see it used. And this is sort of the rationale for the synergy. So typically aminoglycosides, they can't get past the cell wall of a bacteria. They're ribosomal inhibitors, right? So they have to get inside. If you give it with a cell wall synthesis inhibitor, you're essentially breaking up the cell wall and letting it get inside. So it's a pretty cool mechanism. So this is there's 2 ways of dosing aminoglycosides. The first way is sort of the traditional way, which is, Q8 or Q12, et cetera. And then recently, or not recently, maybe about a decade or so ago, there was a new way to dose aminoglycosides, taking advantage of its parameters, such as its peak-dependent killing and then its post-antibiotic effect. So in the black line, you can see that this is the traditional way of dosing. This dashed line here is the MIC. So you can see that aminoglycosides, if you dose it traditionally, they never dip below the MIC. So you're always keeping it therapeutic, which isn't really the best way to optimize its PK parameters. Rather, you want a super high concentration, and then you want it to just fall on its own. And even if when the aminoglycoside falls below the MIC, you know that it has a very strong post-antibiotic effect, meaning that even though the aminoglycoside is gone, it's still exerting some antibacterial activity. So this blue line sort of is more efficacious, and it minimizes nephrotoxicity. So this is sort of peak-dependent killing. You want to give a high dose to sort of maximize this, and then post-antibiotic effect is when it's sort of gone from the system, but it's still working. If you look at our aminoglycoside susceptibilities, they're actually really good, just because no one really uses them anymore. So this has managed to really increase the susceptibilities to almost 100% for amikacin. So typically among the 3, if you want to give something and have it not be resistant, it's going to be amikacin. This is at all 3 campuses for different gram-negative bugs. You can see that amikacin is just, it's pretty amazing. And then for Pseudomonas, again, it's pretty high susceptibility rates. So this is sort of the rationale for double covering patients if you suspect a gram-negative infection, because, for example, you can give them Zosyn, but it may be resistant, right? So you just give them another dose. You just give them a dose of amikacin, and you'll kind of cover them until susceptibilities are back. So this is how we dose patients using extended interval. There's sort of three categories, for synergy, for UTIs, and then for all other infections like gram-negative sepsis. It's broken down into different creatinine clearance cutoffs. You'll find all of this on Stanford, by the way, but you can always take a photo or a screenshot if you want. Typically for Gen and Tobro, we give them three. I know 3 mg per kg doesn't seem like a large amount, but this sort of it's a decent amount. You'll see here that it's even higher for gram-negative sepsis. This is really your true extended interval, like high dose, so 5 to 7 mg per kg. And then for amikacin, it goes anywhere from 15 to 20. For a reference, traditional dosing of aminoglycosides would be like 1 Q8 of Gent. And then the other thing to mention is that you use ideal body weight to dose aminoglycosides, except if patients are obese, then you'll use adjusted. And then if they're underweight, you don't want to overestimate their dosing, so you'll use total body weight. Yeah, I won't go into the dosing schemes too much, but yeah, you can see here that if the creatinine clearance is poor, you may even go to Q48, which is really sort of extended. There's some exclusions to extend. Oh, sorry, let me see. Yeah, I mean, amikacin also is a newer generation aminoglycoside. It's not like that new, but it came out after Gen and Tobra, so it's sort of expanded coverage. So that's sort of why the susceptibilities are so good. For exclusions to extended interval, you want to exclude neonates, burn patients, anyone with a really low creatinine clearance. If they have a really low creatinine clearance, you're just going to dose them traditionally. And you can kind of see here, if I could just go back really quickly, right here below, if it's less than 30, you can see the dose really falls to like 5 mg. This is basically traditional dosing. And then gram-positive synergy for Enterococcus. It's just not studied that well. And also, we don't really use aminoglycosides for Enterococcus anymore. You'll learn that we use something else. So these are sort of your exclusions. But for the most part, most patients can get it. In terms of monitoring, so for the most part, we give aminoglycosides extended interval. We usually give 1 dose, but there may be some instances when you need a repeated dose, and it's pretty easy. So you just give them a dose, you wait about 24 to 48 hours whenever their next dose is due, and you want to check a trough level. And typically, like I said, we're taking advantage of the post-antibiotic effect. So all these levels should be undetectable. So it should be less than 1 for Gent, less than 1 for Tobra, less than 8 for amikacin, and aka undetectable. Yeah, so then if they're undetectable, you can give them a dose. The one thing to note is that Gent and Tobra are performed in-house, whereas amikacin is a send-out. So this could kind of delay you redosing amikacin, but again, most patients are getting 1 dose, so it's not too big of a deal. In terms of conventional, I'm not going to go over too much. This is sort of, you can see the dose. Basically, I just want to point out the dose is low here, and then you're giving it more frequently based on the renal function. Monitoring, yeah, I'm not going to go over this too much. Yeah, it's just more complicated also. So if you need a dosage for RIT, just consult your ID pharmacist. That's all I'm going to say for that. So this is a good example of using aminoglycosides for urinary tract infections. You'll see throughout your consults that you'll have a lot of nursing home patients. They come in with AMS. The team doesn't know what to do. They think it's a UTI. So this is an example we see all the time. 85-year-old female comes in with AMS. You can't verbalize symptoms. You can't say if she has dysuria or not. And the team thinks, okay, possible cystitis. She doesn't weigh that much. Creatinine clearance is low. She's growing this MDR E. coli that's only sensitive to a few things like nitrofurantoin, meropenem. So how would you treat? The best thing you can do is not treat this actually, but sometimes you're kind of hard pressed to give them something. And instead of giving the patient, meropenem for a quote unquote cystitis, you can potentially get away with aminoglycosides. So why are they so good for urinary tract infections? They're excreted 98% in the urine. So it's basically completely urinary elimination. They concentrate in the urine up to 100-fold. And with just 1 mg per kilo of gent, you can get peak concentrations that exceed almost 400. And for reference, the breakpoint of E. coli for gent is 4. So yeah, you're basically totally annihilating the bacteria. Again, you get this post-antibiotic effect, as well as the aminoglycoside kind of just staying in the urine for a long time. And there's pretty low risk of collateral damage with 1 or 2 doses. This was a recent, or not too recent, but it was kind of a systematic review. It looked at single dose aminoglycosides, and it said, should we kind of resurrect this old strategy? So it was 13 studies. They had over 13,000 patients. E. coli was the most common pathogen, and they saw really high cure rates. 30-day cure rates were also pretty high, 73%. And then, everyone is concerned of nephrotoxicity, ototoxicity, and you can see it's pretty minimal. So this is always a good strategy. So we ended up giving this patient gent, because of the low creatinine clearance, we gave her traditional dosing, but this is still sort of high for her because of her weight and her age. So she ended up getting 80 mg per kilo of gent and did fine. Polymyxins, I didn't have this initially because you really shouldn't be using these anymore. Fortunately for us, we have much better agents for multi-drug resistant organisms. I don't know if May or Yi are on this, but I'm sure they have tons of experience using polymyxins. I've only had to use it like once in my entire training and career. So in short, they're bactericidal, they're concentration dependent. It's basically like giving someone detergent. That's what polymyxins are. Yeah, you can see they have this hydrophilic head, lipophilic tail, and they kind of just insert themselves and they cause sort of membrane depolarization. They work against a lot of gram negatives. So, back in the day, there was a good utility for this before we had, like Avycaz, Vabomere, Zerbaxa, all these. It's important to know that they don't cover anaerobes, gram-positive organisms, and then I remember BNPs, so Burkholderia, Neisseria, Proteus, Providentia, and Serratia. They don't cover. So they do have some holes. In terms of the toxicity, this is sort of why we avoid them so much, because they have a very high incidence of nephrotoxicity, as well as neurotoxicity. So this is very well documented, and this is sort of why we don't use them as much, in addition to them also not being that effective. Its place in therapy is sort of a last resort if you really have no other options. You don't want to give them monotherapy, very similar to aminoglycosides, due to just development of resistance. So this is their place in therapy in a trash can. This is sort of the literature looking at polymyxins versus other agents, sort of newer agents. So Colistin versus Avycaz due to CRE. This one was Zerbaxa versus polymyxin due to MDR Pseudomonas. You can see that if you use polymyxins, you have to double cover them. So they saw more double coverage. Despite the double coverage, you see increased mortality with polymyxins and increased nephrotoxicity with polymyxins. So when in doubt, when you have a multi-drug resistant organism, you want to use another agent. So I'm going to go to the next section, quinolones. This is a 55-year-old female with cystitis. She has a penicillin allergy. What would you prescribe for her UTI? You can see that it's a pretty pan-sensitive E. coli. And the answer to this is anything but Cipro. So quinolones are topoisomerase inhibitors. They're concentration dependent, bactericidal, have a long post-antibiotic effect, very similar to aminoglycosides. The only exception here is that they have excellent PO and IV bioavailability. So greater than 90% to up to 100% for certain ones. And this is what separates them from a lot of other drugs and why they're so attractive, because you can basically just put them on PO and you're kind of giving them an IV therapy, basically. In terms of its coverage, Cipro is pretty much a gram negative. Oh, sorry, I see some questions. Let's see. Oh, okay. Nice. See, May said bad memories. So Cipro, it's typically a gram-negative quinolone. It covers, your gram-negative rods, covers Pseudomonas, covers some atypical organisms like Legionella. Levofloxacin expands on that a little bit by adding some gram-positive coverage. So you may have heard that Levaquin is a respiratory quinolone. Not that it gets into the lungs better, but it covers more of your respiratory pathogens like strep. The MSSA coverage is not great for quinolones. Sometimes you may see it used for like prosthetic joint infections, but the coverage by itself, at least as monotherapy, is not reliable. And then Moxie, we don't have on formulary, but basically it's sort of your NTM quinolone, or sometimes you'll use it for like Mycoplasma genitalium. You basically just switch to Pseudomonas and anaerobic coverage because it also covers anaerobes with Levaquin. Some side effects, I'm sure you guys have heard of this. A lot of tendinitis, tendon rupture, aortic aneurysm is a new one. A lot of C. diff, QT prolongation. Among the agents that prolong the QT interval, Cipro is the least likely, and these are your only oral anti-pseudomonal agents. So for this reason, I always like to preserve them, and you see a lot of guidelines sort of discouraging quinolone use for simple infections nowadays, like diverticulitis, UTIs, stuff like that. You want to try to spare these agents for when you really need it. Something to remember, you have to separate them from cations. So things like iron, calcium, milk, sometimes when you counsel patients to just not take them together and separate them by a few hours. So quinolones are not benign. I just want to stress this point. There's been numerous FDA communications saying that has all these side effects, and you really should sort of reserve them. Quinolones have been strongly associated with C. diff. So this study looked at different risk factors among different antibiotics. You see that quinolones and clindamycin are kind of your main culprits here. Quinolones can also increase your risk of MRSA. So this was another study looking at that. And then typically in terms of efficacy, quinolones don't really have the greatest gram-negative coverage. So, we see it a lot for intra-abdominal infections. Ciproflagell is like a go-to for surgeons, right? The most common bug in intra-abdominal infections is E. coli, and you can see that you're kind of missing 1/3 of E. coli. And for other organisms, it's not great. If you look at ceftriaxone, you can see that it's much better. And typically, when you're on stewardship or something like that, the go-to agent for, like an intra-abdominal infection or something of that nature is typically, we want to go to ceftriaxone flagell instead of ciproflagell. For UTIs, if you're treating E. coli, macrobid is sort of your go-to. Like the susceptibility is really great here, and Bactrim is pretty comparable. So quinolones are preferred only in a few cases. Again, they're the only oral anti-pseudomonal agent. They're one of 2 oral agents for ESBL gram-negative bacteremia, the other being Bactrim. So if you have an ESBL gram-negative bacteremia, if you have quinolone susceptibility, that's great because you don't have to line up the patient and send them out on a carbapenem. And then bone and joint infections is your other niche. In terms of linezolid, basically it's kind of like your gram-positive agent on steroids. So you can see that if you remember Vanc, it had some holes for like VRSA and VRE. You can see linezolid covers all of them. There's no gram-negative coverage. In terms of how it works, it's a 50S ribosomal subunit inhibitor. Because of this, you may see it sometimes used for toxin suppression, very similar to like how we use clindamycin. And it's really the drug of choice for VRE, skin and soft tissue infections, sometimes non-tuberculosis mycobacteria. It gets into tissues really well. So skin, lung, bone, CNS. The only exception is the urine. It doesn't really get into the urine that well. So we try not to use it. The bioavailability, again, is great. So there really shouldn't be a reason why patients are on IV linezolid. If you can give them PO, then that's perfect. And dosing is easy. It's 600 BID for everybody. So I have a quick question here. Which side effect is associated with linezolid? Is it A, serotonin syndrome, B, optic neuritis, C, peripheral neuropathy, D, thrombocytopenia, or E, lactic acidosis? Okay, so I see a lot of choices. It's actually all of them. So I'll kind of go through the unique mechanisms of each. So linezolid has some weak monoamine oxidase inhibition. So if you give it with a serotonergic, it can precipitate serotonin syndrome. And this is sort of one of the feared complications, although I'll explain, it doesn't really happen too often. This is really unpredictable in terms of its onset. In terms of the other four, these are really due to direct mitochondrial toxicity because of its 50S inhibition. And these are typically duration dependent. So after like 2-3 weeks, this is sort of why we don't continue linezolid for a long time, because we can run into some of these side effects. In terms of the risk of serotonin syndrome, you really have to look at the number of serotonergics, the dose of the serotonergics, and the type. So some of these serotonergics aren't really pure, serotonergics. And if you're just on one, it's typically okay. So you can still give linezolid. When providers go to order, they're going to get this big red warning, right? And it's just sort of up to you to know that if they're on one, maybe the dose is low, or if they're on two and the doses are low, it's typically okay to give. One thing to note is that there have been studies published on the risk of these mitochondrial toxicities if patients have CKD or ESRD. So although we don't dose adjust it, it is, again, 30% renally cleared. So there is a risk for accumulation in these patients, and they're kind of at slightly higher risk for developing these four toxicities here. So that's just something to keep in mind. I'm going to move on. I think I have 2 classes left. So this is a 54-year-old female, secondary peritonitis due to colon perf, also C. diff positive, found to have multiple intra-abdominal abscesses on imaging and septic shock. The abscesses were drained, and they're growing mixed bacterial species with many yeast. How would you treat her? So this isn't a fungal question, but rather it's one drug to treat them all. So we're going to talk about ravacycline. This is sort of a newer tetracycline. It's a cousin of Tigasil. So for your reference, sorry, let me see. Okay, for your reference, we don't have Tigasil anymore on formulary. We've replaced it with a ravacycline. It covers ESBL organisms, covers AMP-C, covers CRE, covers XDR Acinetobacter. So actually, the coverage is great. Of note, it doesn't cover the 3 Ps, so you have to keep this in mind. It's Pseudomonas, Proteus, and Providentia. It does not cover any of these organisms. Dosing is pretty straightforward. It's 1 mg per kilo, Q12, and if they have some hepatic impairment, you reduce it to daily. If they're on any strong 3 or 4 inducers like rifampin or some of your like anti-seizure medications like phenytoin, you'll increase the dose. The one big thing about Tigasil, why we sort of avoided it, was that the gastrointestinal side effects were a lot. So patients would experience a lot of nausea, vomiting. It's still present, but less so than Tigasil. The one thing to note is that a ravacycline, like Tigasil, still has a high volume of distribution, meaning that it gets into tissues really well, but it doesn't really stay in the bloodstream, which is great if you're treating like, intra-abdominal, skin and soft tissue. But if you're treating a bacteremia, you're not really going to have too much drug in the bloodstream. So this is why we sort of avoid it in bacteremia. Same thing with UTIs. So the niche is really for intra-abdominal infections. It actually has some activity against C. diff, although we're not really going to use it as a sole agent for C. diff. But in this case, the patient had concomitant C. diff, so we said might as well try it. And this patient actually did very well. So we gave them, mica for the yeast, Piovank for the C. diff, and a ravacycline, and they actually resolved their sepsis. Ravacycline was continued for 14 days from drainage. And this is where I plug my my royalties from the drug manufacturer. I'm just kidding. Just kidding. So the other tetracyclines that we'll talk about are Doxy and Mino. They're pretty broad agents, really. Doxycycline is kind of your drug of choice for skin and soft tissue. So you can see that it covers MRSA, MSSA, covers some strep, covers some atypicals, and we use it a lot for tick-borne diseases. Minocycline is kind of your drug of choice for your more resistant gram negatives. In particular, you're going to use it a lot for Centrotrophomonas. And then eravacycline, like I mentioned, it covers basically everything but Pseudomonas, Providentia, and Proteus. They all have pretty good bioavailability, or excellent bioavailability, actually. It's all 1-to-1. So again, always give these PO unless there's a strong reason not to. The only thing is that they're kind of static agents. So a lot of the agents we talked about previously were cytal. So this is sort of your one static agent. And then again, the poor urinary penetration and high tissue distribution is sort of a plus and a minus. And the last class here, or last agent, is fosfomycin. This really just has one niche. It's for resistant urinary tract infections. It's kind of an old drug and it was kind of repurposed. It's a cell wall inhibitor. I won't go through all this. That's how it works. And the FDA approved indication is uncomplicated UTI in women due to susceptible strains of E. coli and E. faecalis. In clinical practice, we're using it for other things. It's definitely not indicated for pyelo or perinephric abscesses because this is strictly a bladder drug. It does not get into kidney tissue very, very well at all. The spectrum is pretty wide. The only thing it doesn't really cover from the gram-negative side is Acinetobacter. CLSI does give a breakpoint for E. coli and E. faecalis. It's less than 64. The issue here is that they say pretty clearly in their disclaimer, you can't really extrapolate this MIC cutoff to anything else. So sometimes we'll have like a CLEB or Enterobacter that we want to send the patient out on fosfomycin. You just have to be careful when interpreting the MIC for that because you can't really extrapolate the breakpoint. This is a European breakpoint. The good thing about phospho is that there's pretty little cross resistance and between phospho and other classes. The dosing is pretty simple. It's 3 grams. You mix it with a few ounces of water. It comes as like a powder. You take it for 1 dose for uncomplicated cystitis. And then if it's more sort of complicated or, maybe the organism is a little bit more resistant, you can kind of give every 2 to 3 days, which is an off-label dose. Insurances typically don't approve this. The place in therapy for us is if the UTI is, associated with the MDR organism or Enterococcus, you need to put them on something PO. This is a good agent. And you sort of need to request add-on testing from Microlab because the susceptibilities don't get published routinely. This is some new data looking at phospho for prostatitis. As you may or may not know, prostatitis, typically, or a chronic prostatitis needs a long course of therapy, like 4 to 6 weeks to treat. The issue here is then if you have sort of an ESBL prostatitis, are you going to line the patient up and put them on ertapenem or meropenem for 6 weeks? So they started looking at fosfomycin for prostatitis because it actually gets into the prostate a good amount. So you can see sort of these extended dosing regimens. The issue when you give fosfomycin too frequently is that they run into a lot of GI side effects. So a lot of these studies, one of the main side effects they reported were GI intolerance, obviously insurance issues as well. That's pretty much it. I will take any questions. Oh yeah, May mentioned 99% of our E. faecalis is sensitive to AMP. Yes, that's correct. So yeah, if you ever see E. faecalis, whether it's vanco resistant or not, it's usually always sensitive to ampicillin. So you can just get away with the MOX too for those cases. All right, if there's no questions, I think I'll just end it. I don't know when this was supposed to end, but I think we're pretty good on time. So nice meeting everyone. And yeah, no problem. See you guys around.
That's a quick question if you're still there.
Yeah, what's up? Sorry, I think I muted myself.
Oh, sure. I'm just curious, in terms of the synergistic use of aminoglycosides, when would we prefer that over switching the, let's say, cefepime or to extended interval dosing?
Sorry, so the question is when we would, could you just repeat it again?
Sure. So for synergistic dosing with aminoglycosides, is that preferred to using beta-lactam monotherapy with extended interval?
Oh, I see what you mean. Yeah, I mean, for the most part, we give synergistic aminoglycosides, like when we want to avoid escalating to like meropenem, for example,
Mhm.
or sometimes if it's like CRE, we want to avoid escalating it to like Abicaz. So you're kind of just giving, your backbone of like Zosyn or cefepime. I mean, you can give those extended as well, but you're adding on the aminoglycoside to almost avoid escalating too quickly, if that sort of makes sense. Once susceptibilities are back, you can peel off the synergistic coverage.
Okay, that makes sense. Okay, that makes sense.
Yeah.
So then I think that answers my next question too, because then if you don't have susceptibilities, you wouldn't know that something is like an MC bug.
Yeah, exactly.
Okay.
Yeah, it's just if someone's in septic shock, you don't want to like take the risk, but at the same time, you're like hesitant to escalate them. You can kind of just get away with double covering them until susceptibilities are back. And then if susceptibilities are back and it's resistant, you just you have that aminoglycoside kind of on board for the time being.
Okay, thank you.
Yeah. All right. See you around. If you have any other questions, feel free to reach out.
Will do.
Yep.
Have a good day.
Yep. Take it easy. Bye.